Good morning. Department of Nuclear Medicine is a SGPGI video pharmaceutical therapy of neuroendocrine system. As we know that the neuroendocrine tumor are a rare type of cancer that can develop in the various organs throughout the body. Most commonly in the gastrointestinal, pancreas, and the lung. And the diagnosis depend upon the high index of clinical suspicion followed by the various imaging technology. The choice of treatment is highly individual, so what we want is a collaborative system from the multidisciplinary team comprising from the various departments like gastroenterology, nuclear medicine, oncology, radiotherapy, endocrine surgeon, and the pathology. Notably, the recent advances in the receptor-based imaging through the PET-CT can have significantly enhanced the diagnostic capability. Additionally, the incorporation of the radiopharmaceutical therapy has become an integral component of neuroendocrine tumor treatment. The Department of Nuclear Medicine is presenting the case of various neuroendocrine tumors and sharing its initial experience of treatment with the radiopharmaceutical. So now I invite Professor Dr. P.K. Pradhan and his team to present this feedback.
Good morning to all of you. Today, the nuclear medicine will present to you regarding the radiopharmaceutical therapy of neuroendocrine tumors. I think as you all know, that neuroendocrine tumors are a group of tumors which are completely heterogeneous and they originate from neuroendocrine cells and it can arise from any part of the body. And these neuroendocrine cells found in various organs, like already told by Dr. Yadav, that it can address the GI tract, pancreas, lung, and adrenal gland mainly, but nevertheless, it can occur anywhere in the body. Sometimes it affects the genitourinary system, the nervous systems. So one can see, and these patients, which really originate from the neuroendocrine cells, they secrete many peptide hormones, for example, like somatostatin receptor expressions, and they also have expressed various peptide receptors, like somatostatin receptors, the glucagon-like peptide receptors 1, GLP-1, or cholecystokinin receptors 2. These patients can present to any clinic of a hospital and with various vague symptoms like dyspepsia, vomiting, recurrent abdominal pain, or some intractable cough or occasional hemoptysis, which depends on the involvement of the respective organs. Once it's suspected, further structural imaging is done with normally ultrasound, which is quite easy and approachable, accessible. And the contrast enhanced CT scan, sometimes we do triphasic CT scan, and subsequently with MRI or endoscopy are usually done in the traditional manner, which follows mostly histopathology evaluation with immunohistochemistry or cytochemistry. And however, in the recent years, mostly the molecular imagings and with PET-CT, and mostly these are receptor-based, they have become very important and they have an incremental role because the tiny metastasis which presents from the neuroendocrine tumors, they are picked up much better in comparison to the contrast enhanced CT scan or MR. That's the major reason for its diagnosis. And on this basis of peptide receptors, I think in the different, which I enumerated already for imaging, on this premise only the radiopeptide therapies are also well developed, which are already in the practice now. And this has guided also this molecular imaging for different kind of therapeutic strategy. If you have a solitary lesion, obviously it will go for the standard surgery, which is the primary cornerstone of the treatment. And subsequently, they're found to be metastatics. Obviously, the other things like radiopeptide therapy or chemotherapy, besides your standard treatment for somatostatin analog for amelioration of symptoms or some anti-proliferative action with this. I think today you have already listened to this that the nuclear medicine will present. I think I will invite my colleagues, Dr. Vineet and Dr. Kanis, who will they present with initially to introduction of this subject because and subsequently with initial cases and then our little initial experience which we have over years and so now I invite Dr. Vineet for presenting this figure.
Thank you, sir. Good morning, everyone. So, as Pradhan sir has elucidated, neuroendocrine tumors are a heterogeneous group of neoplasms that originate from neuroendocrine glands and endocrine islet cells within the glandular tissue. These are the malignancies which can involve almost every organ. However, these are a rare kind of malignancy, constituting about only 0.5% of the all malignancies. The incidence lies approximately 3.5 per lakh population in the US, and Indian data shows its incidence about 2 person per lakh cases. However, within the last few decades, it has been noted that the incidence of the neuroendocrine tumor has increased gradually with the advent of new diagnostic technologies, whereas the incidence of the rest of the malignancies remains almost same. This is another data from CR9 registry, which is showing that among the neuroendocrine tumors, incidence of the small intestine neuroendocrine tumor and rectum intestinal tumor, neuroendocrine tumor, has increased mostly in number in compared to other neuroendocrine tumors. And mostly small intestine and pancreatic that constitute JEPNETs, gastroenteropancreatic neuroendocrine tumors, are the most common, which turn out to be malignant. These patients with the neuroendocrine tumor generally present with a vague variety of symptoms like edema, diarrhea, nausea, vomiting, GI bleed. They may also present with some cardiac diseases. So before diagnosing for neuroendocrine tumors, first we have to rule out all the other relevant pathologies, and then only we can go towards diagnosis of the neuroendocrine tumor. These symptoms depends on the origin of the vasoactive peptides releasing from the sites. So broadly, this can be classified, neuroendocrine tumor can be classified, whether they are pancreatic in origin or non-pancreatic in origin. Among non-pancreatic in origin, they could be functioning or non-functioning. The functioning one could be originate from pulmonary, gastrointestinal, and other sites. Mainly, they produce the symptoms of carcinoid syndrome, which may land up in carcinoid crisis, or 10 to 20% of carcinoid syndrome patient may end up in carcinoid heart disease. The pancreatic one are mostly non-functioning, but around 40% are functioning. Among functioning, depending upon the vasoactive peptides they release, they could be insulinoma, gastrinoma, glucagonoma, VIPoma. These the conventional diagnostic procedure are the estimation of serum chromogranin A and HIA, and these are followed when there is suspicion of carcinoid syndrome, and they are followed by conventional imaging like USG, CT, or MRI. And if there is a solitary tumor, then generally surgical or endoscopic section remains the primary treatment modality. Most of these, as we have already seen, 60% of neuroendocrine, most of these are non-functional, but some cause symptom. However, the most around 60% of the neuroendocrine tumor are metastatic at the time of diagnosis. So, treatment involving surgical resection may not be the only choice available at that time. It has been seen then that 80 to 90% of gastroenteropancreatic tumor will express somatostatin receptor. Why this peculiar receptor is important? Because this is the receptor when combined with somatostatin analog or somatostatin ligand, they causes anti-proliferative and anti-secretory effect. So these leads to the advent of the octreotide and somatostatin analog by 1990s for the treatment of the functional neuroendocrine tumors, and also it has become the basis for the functional imaging and our neuronuclear therapy, that is PRRT. Among the somatostatin receptors, the most common one is somatostatin receptor type 2. They could be from somatostatin receptor type 1 to type 5, but most commonly which is expressed is somatostatin receptor 2. So this becomes a target for our functional imaging as well as our therapy. The grading of the nuclear neuroendocrine tumor depends on the mitotic rate and Cas67 index. Mitotic rate is number of mitosis per area unit of tumor, and Cas67 index is the proliferation marker. As these mitotic counts and Cas67 index increases, the grade of the tumor increases. With the increase in grade of tumor, the prognosis and it decreases, and so survival also decreases, as we will see later on in these slides. So these neuroendocrine tumor could be well differentiated or poorly differentiated. Poorly differentiated are called neuroendocrine carcinoma, and there could also be a mixed variety of cells. So that is mixed neuroendocrine, non-endocrine neoplasm can also be there. Since 1990s, after the advent of the somatostatin analogs, the treatment modality for non-resectable tumors became either somatostatin analog or chemotherapy. But these tumors are predominantly chemotherapy resistant. So for the functional disease, somatostatin analog became the primary treatment, remained the primary treatment. However, and there was one meta trial conducted between 2012 and 2016 by some scientists in Florida, and these were the randomized controlled trial phase 3, in which one arm was taken as octreotide LAR, long-acting octreotide, administered every 4 weekly, and the second arm was injecting 177 lutetium dotatate with long-acting octreotide every 8 weekly for the 4 cycles, and the patients were followed up for 5 years. And the results of this trial became the one of the reason of the including this PRRT into the various guidelines. After that, its approval in by FDI in 2020, and thus this PRRT become a part of various guidelines where surgical section is not possible as a treatment after somatostatin analog refractory disease in the metastatic neuroendocrine tumors. So we have listened about PRRT. So what does it stand for? This PRRT, what it stands for? Peptide receptor radionuclide therapy. What we do in this? We do systemic administration of radio-labeled peptide. So there is 2 words, radio-labeled and peptides. So peptides are the one which get attached with somatostatin receptor, and they are attached with some radioisotope which produces beta, gamma, alpha radiation depending upon their nature. So these radio-labeled peptides, they target the receptors which are overexpressed on the various tumors with high affinity and specificity, since they are specific for these receptors. Now the radioisotope part of that radio-labeled peptide releases beta or alpha ray from the radio tracer, which deliver radiation dose to tumor, producing its effect. So how does this PRRT specifically work in neuroendocrine tumor? As we have already seen that neuroendocrine tumor cells have overexpression of these somatostatin receptors. So we have a somatostatin analog, that is dotatate, which gets attached, which we attach with the 177 lutetium, and it become 170 lutetium 177 DOTA-TATE. This is the radiopeptide with the medium energy beta radiation, and its mean range is in cells is about 2 mm. So after the administration of this somatostatin log linked with 177 lutetium radionuclide, that is 177 lutetium DOTA-TATE, it gets attached to its receptor on the tumor cells, and it gets internalized within the cells, where due to the production of beta rays, this causes DNA damage, predominantly single-stranded DNA damage, and resulting in the death of the tumor cells. With this context, we have to see for whether the patient PRRT is a suitable therapy for patient or not. So first we see whether the PRRT is a suitable therapy or not. For that, first we have to prove that in the tumor is neuroendocrine tumor, and this should be proven with histopathology and immunohistochemistry. Second, we have to look for the high somatostatin receptor expression, which is determined the DOTA-NOC or DOTA peptide PET-CT. Then we have to look for the tumor differentiation. Since well-differentiated tumor produces high amount of somatostatin receptor, and so they are preferred for the therapy. And also we have to look for tumor proliferation rate, and preferably with a Ki-67 less than 20% are preferred for this therapy. We have also to look for whether the patient is suitable for this therapy or not. For this, first we have to look for hemodynamic parameter. Since bone marrow is a critical organ, this therapy may affect bone marrow. So bone marrow adequacy, we have to look for it. Second is kidney functional status. The route of excretion of this lutetium DOTA-TATE is kidney. So kidney gets exposure to the radiation. So we have to ensure that GFR is at least 60% of the normal value for that before administering this therapy. Also, we have to look for the liver function status, which is the most common of site for metastasis of gastroenteropancreatic neuroendocrine tumors. Based on these factors, these are the pre-therapy workup we generally do, depending upon the patient. So hemogram include hemoglobin, TLC, DLC count. Mainly lymphopenia can occur, so we have to look for the TLC count and also the hemoglobin level. Then serum creatinine, GFR to look for the kidney function. LFTs to look for the functioning liver status. Serum electrolyte we have to look for, as we will see later on, that one of the side effects is dyselectrolytemia. So we have to first look for that serum electrolyte within normal range or not before administering this therapy. Then we also have to look for the neuroendocrine tumor markers. This 24 urinary HIA is a functional marker which is a metabolite of the serotonin. So if it is increased, it is a high chances that serotonin level is increased. So it is a functional marker. Second is serum chromogranin, which is expressed by neuroendocrine tumors. Then we also have to do functional imaging, that is gallium-68 DOTA-NOC PET-CT, before to look for the SSTR expression. The timing of the this scan when we do, we will discuss it later on. So after these indication, we also have to look for the whether it is contraindicated or not for the patient. The first absolute contraindicated is if there is any other curative approach possible. Since this therapy is palliative, not a curative one. So if a curative approach is possible, that should be preferred choice and not this therapy. Second, later on, these contraindications are predominantly radiation safety dependent, like pregnancy, severe acute concomitant illness, and severe unmanageable psychiatric disorder. So patient cannot follow the radiation protection protocols. The relative contraindications include breastfeeding if patient refuses to stop breastfeeding permanently, and severely compromised renal function and severely compromised bone marrow function also becomes a relative contraindication for this therapy. Depending upon the renal and hemodynamic function of the patient, the dose administered to the patient is decided. If the functioning is adequate, then generally we give a empirical dose of 150 to 200 millicuries till 3 to 6 cycles, and the interval between each cycle remains 6 to 12 weeks. The patient who have compromised renal and hemodynamic function, in those patients, we lower the activity of the administered dose, and generally 100 millicurie is preferred to prevent further injury to bone marrow or kidneys. So since we have listened a lot that kidney is an important organ to preserve, so how do we do it? First thing, choosing the appropriate radionuclide, which can cause less injury to the kidneys. So that's why we prefer lutetium dotatate. Second is inhibiting the renal uptake of radiopeptides. Radiopeptide, this could be done with the simultaneous infusion of the amino acids, which expresses positive charge and competitively inhibit this intake of radiopeptides into the proximal tubular cells. And third is reducing harmful effect of radiation. This could be done with the administration of the radioprotective agents, which generally is not done. Based on this knowledge, this is the protocol we follow for the administering this therapy to the patient. First, we start with pre-medication. Anti-emptying is given to the patient, predominantly 5-HT3 inhibitor, half an hour before the administering of the amino acid infusion, and dexamethasone is given. After that, amino acid infusion starts firstly at the rate of 30 drops per minute, and half an hour after starting this amino acid infusion, we start injecting lutetium dotatate for half an hour. After the completion of the injection of the lutetium dotatate, this amino acid infusion continues for next 4 hours. And this is a day-care based therapy. So patient is generally released on the same day, as the radiation level released from the patient is generally normal for the public exposure. So after this therapy, we do post-therapy imaging 24 hours after this therapy. This imaging is done first to look for the localization of activity into the lesion, whether this radioactivity has been penetrated into the lesion or not. Second, dosimetry. This is done to limit the radiation depth to critical organs, that is predominantly kidneys and bone marrow. So generally, we first do a PET-CT, that is rotanak PET-CT, before the administering this therapy. After that, we administer 3 cycles of this therapy. After that, one interim gallium-68 rotanak PET-CT is done to assess its effectiveness. If there is a response, either a stable disease or partial response, then 3 more cycles of PRRT are administered. And after completion of 6 cycles, rotanak PET-CT is again done for response assessment. However, if there is disease progression after the 3 cycles of the this PRRT therapy, then next line of management is sought for. Depending upon the situation, this therapy can also be rechallenged or given to the patient again. So this should be administered only when the clinical benefit of this therapy outweighs the risk associated with progress of disease. When this therapy is re-administered, then 1 to 2 cycles of this therapy is administered, and after that, PET-CT is done to look for its effectiveness. During this re-therapy, same or different radiopeptide can be utilized depending upon the situation. So, does this therapy have side effects? Yes, like any therapy, it has side effects, but these are not very, generally we do not see these side effects. Predominantly the side effects we encounter are the nausea, vomiting and fatigue, and they are mainly due to simultaneous infusion of amino acids. Other could be electrolyte imbalance, predominantly hyperkalemia, hypernatremia. In a few cases, less than 1% of patient may end up in carcinoid crisis due to the hypersecretion of the vasoactive peptides. Among the subacute side effects, most common is myelosuppression, which is predominantly grade 1 and grade 2, and most often they are reversible. However, in 10% of cases of myelosuppression, it could increase up to grade 3 or grade 4. As we have discussed earlier, the nephrotoxicity is a long-term side effect with grade 3 or grade 4 in less than 1.5% of cases. Also, there are reported cases of leukemia and myelodysplastic syndrome, which are predominantly seen in patients who have already received chemotherapies. And it has been seen into 1 to 2% of cases, but has been never seen in our own experience. This PRRT can also administer in other non-neuroendocrine tumors, which have significant expression of the somatostatin receptors, like radioiodine refractory neuroendocrine tumor, thyroid cancer, pheochromocytoma, meningioma, medullary carcinoma of thyroid. If there is sufficient expression of this somatostatin receptor, patient may be chosen for PRRT if there is a need. Based on this context, now I would like to invite my colleague, Dr. Kanish, who will take us further into our some interesting cases and our experience with this therapy. Over to Dr. Kanish.
Thank you, Dr. Vineet, for the introduction to peptide receptor radionuclide therapy. I'll be taking forward with the cases and our initial experience with the radionuclide therapy. So coming to the first case, this is a case of a 51-year-old female who presented with complaints of sudden onset abdominal pain in 2020. She underwent contrast-enhanced complete tomography of the abdomen, and it was found out that she had a heterogeneously enhancing lesion in the tail of pancreas with multiple hepatic lesions. On the histopathology of the liver lesion, it was found out that it was a metastatic neuroendocrine tumor. Since it was unresectable, she was referred to us for peptide receptor radionuclide therapy. I'll take you to the baseline gallium proton PET CT scan of the patient. So I'll take some time here to tell you about the physiological tracer uptake. As you can see, there is uptake in the pituitary, some uptake in salivary glands, some in thyroid. This is the blood pool that you can see. The uptake, some uptake that you can see in this blue color is physiological in the liver as well as in spleen. And as Dr. Vineet has already pointed out, that bilateral kidneys and urinary bladder is the route of excretion. So as you can see in this image, that there is significant metastatic liver that are gallium proton avid in both lobes of liver, as well as there is a lesion in the tail of pancreas. This patient was given 6 cycles of lutetium-177 dotatate therapy, and after doing the scan, after this 6 therapies, it found out that there was significant response in the liver lesions, as well as decrease in the standard uptake value of the tail of pancreas lesion. We can also see that our imaging response is directly in correlation with the response in serum chromogranule levels. And they have gone from 492 to sub 20 levels. The learning point from this patient is that there can be partial response in pancreatic neuroendocrine tumor, and our imaging response is in direct correlation with decrease in the symptomatology of the patient. Coming to the second case, this is the case of a 37-year-old female who presented to us with complaint of epigastric pain in 2017. She underwent complete tomography of the abdomen, and it was found out that she had a short segment duodenal wall thickening with multiple liver space occupying lesions. On upper GI endoscopic histopathology, it was found out that she was a case of neuroendocrine tumor grade 1 with a Ki-67 index of less than 1%. This is the baseline gallium proton PET CT scan of the patient. As we can see, there are multiple lesions in the liver, especially in the right lobe. This patient was given 6 cycles of lutetium-177 dotatate therapy. And on the post-therapy gallium proton scan, we can see that the burden of disease has significantly reduced, as well as there has been significant response in the serum chromogranule level of the patient. The learning point from this case is that there can be partial response even in grade 1 duodenal neuroendocrine tumor, and it correlates with the decrease in symptoms. Coming to the third case, this is a case of a 55-year-old female who presented with complaints of diarrhea since 6 months. The patient underwent computed tomography of the abdomen, and it was found out that there was a heterodense lesion at the head of pancreas with few small periportal lymph nodes. Classical keratoconductomy was done on this patient, and on histopathology, it was found out that it was a grade 3 neuroendocrine carcinoma. The patient was on follow-up till 2018 when she was again presented with complaints of fever and diarrhea. On computed tomography, she was found out to be having multiple liver as space occupying lesions, and they was done as query metastatic. On due to her symptoms, she was started on injection sandostatin since this was functional tumor, but her symptoms persisted and she was then referred to us for peptide receptor radionuclide therapy. This is the baseline gallium dotanol PET CT scan. As we can see, there are multiple liver lesions, and she was having the clinical symptoms of fever and diarrhea. After giving 3 cycles of lutetium dotatate therapy, there was significant reduction in her lesions, as well as there was complete resolution of her symptoms. And as we have seen that this was a patient of neuroendocrine carcinoma, so we see that there is a very good partial response in this patient in neuroendocrine carcinoma, and there was reduction in symptoms, and that helped the patient. Coming to the fourth case, this is the case of a 72-year-old gentleman who complained of persistent cough in 2016 on HRCT thorax. He was found out to be having consolidatory lesion in the left lower lobe of lung with no other metastasis or site of lesion seen in the visual field. On histopathology of this lesion, it was found out that it was a differentiated neuroendocrine tumor of grade 2. And he underwent, since it was a solitary lesion, he underwent the left lower lobe lobectomy in 2016. This patient was kept on regular follow-up, and he again presented with complaint of dyspepsia and lower backache in 2018. This patient then underwent gallium dotanol PET CT baseline scan, and as we can see, the patient is having disseminated metastasis in all his visualized axial appendicular skeleton, as well as multiple metastasis in his liver. The patient underwent total of 6 cycles of lutetium dotatate therapy, and we were able to help the patient to achieve stable disease status. The patient was kept on regular follow-up on serum chromogranin levels as well as on symptomatology, and it was on May 2023 that the patient came back to us with the complaint of lower backache, and he was having a visual score of pain score of 6/10, and he was managed on oral analgesics. We did again a gallium dotanol PET CT scan. It was found out that he was having increase in the standard uptake value of his previously seen lesions. So the patient then underwent other 2 cycles of gallium dotanol, lutetium 177 dotatate therapy, and he was found out to be having a complete resolution of his pain, and the patient is now under follow-up. As we can here also see that the patient started therapy in 2018, and there was a sudden increase in 2023 that is corresponding with his pain. And we again, after giving the therapy, there has been seen a decrease in the serum chromogranin levels. So stable disease response was achieved in a grade 2 metastatic bronchial neuroendocrine tumor. And from this case, we can take away that retherapy is a viable option in case the patient symptoms reappear or there is a progressive disease seen on our subsequent gallium dotanol PET CT scans. Coming to the fifth case, this is the case of a 35-year-old male patient who complained of recurrent vomiting for 3 years. The patient underwent computed tomography of the abdomen, and he was found out to be having multiple cystic and heterogeneous lesions in both lobes of liver. The patient was kept on symptomatic treatment, and his symptoms aggravated again in 2019. Again, he was kept on symptomatic treatment only, and he ultimately underwent US-guided biopsy, which found out to be having a differentiated neuroendocrine grade 1 tumor in 2022, since he already had a disseminated metastatic disease and it was unresectable. So he was then referred to us for peptide receptor radionuclide therapy. This is the baseline gallium dotanol PET CT scan of the patient. As you can see, the bulk of disease lie in both lobes of liver, with both lobes of liver are enlarged. This patient underwent 3 cycles of lutetium 177 dotatate therapy, and no significant decrease is noted in the number of lesions as well as in the standard uptake value of the patient. So this is one of the few examples that we see of the patient with rising in the titer of serum chromogranin and no relief in the symptoms of the patient, and a rare example of a non-responder in a grade 1 metastatic neuroendocrine tumor. So for this patient, he was ultimately referred for the next line of therapy because his symptoms have persisted. So in this types of patients, we can then again go for further protocols of capecitabine as well as temozolomide along with our peptide receptor radionuclide therapy. As well as there are newer protocols that incorporate everolimus along with our lutetium prototype therapy, as well as newer immunotherapies that are currently in clinical trials. As we can see, the chemotherapy takes care of the lesions, and in these cases, we usually do FDG PET-CT scan to see the tumor heterogeneity. And we have seen that on giving the capecitabine therapy, there has been an anatomical imaging response in about 45% of patients, as well as a disease control in at least more than 80% of the patients. So coming to our SGPGI experience, we have started giving peptide receptor radionuclide therapy in 2015 in SGPGI-MS. We mostly cater to the North Indian demographic, but patients from all over the country comes to us. At least till now, we have done a total of 39 cases of gastroenteric pancreatic neuroendocrine tumors, and more than 167 doses of lutetium prototype therapy has been administered. We can see mostly our patients have been of the male population. Out of the total number of cases that we have done till now of gastroenteric pancreatic neuroendocrine tumor and bronchial carcinomas, we can see that mostly the patient have been of the pancreatic and small bowel variety. The treatment response in patients post 4 cycles of chemotherapy has been seen that the most common response achieved was stable disease in patients, as well as the next one being 1/3 of patients underwent disease progression, and the rest were having partial response to the therapy. We can correlate this data with the international data that can be seen that the most common response seen is either partial response or mild response to the disease. And multiple patients' data that we can see in thousands have also revealed that the most common response to the therapy has been the stable disease for the patient. As we can see from the median survival curve for the localized and metastatic neuroendocrine tumors, the patients with distant metastasis have a median survival of only 2.7 years and localized disease of about 20 years. So resectability is possible, should be done. And we can see the patients are having a dismal diagnosis if they have distant metastasis. In the observed 5-year survival for gastroenteric pancreatic neuroendocrine tumors, we can see the pancreatic neuroendocrine tumors, which consist the bulk of our referrals, are having the poorest 5-year survival rates. With the correlation of the tumor grade that has been told by Dr. Vineet, we can see that the grade 3 neuroendocrine tumors are having the worst prognosis in the cumulative survival. Coming to the NETA-1 trial that was introduced, we can see that the progression-free survival is better when the lutetium dotatate therapy is given along with the sandostatin as compared with the controls. And we can see with the overall survival as well that we come above the single cold given to the patient. The midgut neuroendocrine progressing during the somatostatin therapy along with the lutetium dotatate resulted in an 18% response rate versus the 3% response rate that is seen if only cold octreotide is given to the patient. So where does we stand in the guidelines internationally? The prerequisite that have only been told that the expression of SSTR by tumor is important and it should be functionally assessed by the gallium dotanol PET-CT functional imaging. In the NCCN 2023 guidelines, it is said that any progressive advanced locoregional grade 1, 2, 3 neuroendocrine neoplasm should be referred to us and we come under systemic therapy for that. In European guidelines, it is said in 2021 that any patient with midgut neuroendocrine neoplasm with somatostatin analog refractory disease should be referred for peptide receptor radionuclide therapy. In ESMO guidelines, it is kept as a second-line therapy in patients with midgut neuroendocrine neoplasms with disease progression in somatostatin analogs. And we have our Indian guideline as well. So what is the take-home message that we can get from this presentation? Well, the peptide receptor radionuclide therapy is a good option for metastatic patients of neuroendocrine tumor. It is based on the receptor expression of the somatostatin receptors that is overexpressed on these cells of neuroendocrine tumors. there should be an increased awareness for neuroendocrine tumors, as it is a rare disease that we can see in our population. That we see that in our population is 2% per lakh population, and the clinical signs and symptoms can be very vague. We can have already seen in our evidences that it is having a better progression-free survival and overall survival for the neuroendocrine tumor patients if we give the peptide receptor radionuclide therapy in conjunction with somatostatin analog than giving the somatostatin analogs alone. And the peptide receptor radionuclide therapy is already approved by the European and the US agencies for administration in 2020. I would like to give my sincere acknowledgement to the help of all the departments. And thank you for your participation.
Thank you, Dr. Binit and Anish for the presentations. I think the most important thing is if you have a vague symptoms and you should have a high index of suspicion and it can present to any clinic. And they are quite heterogeneous and there is a very increasing incidence you saw very specifically for the small intestine and the rectum, if you organ-wise go. And if they are functional by measuring the serum chromogranin or 24-hour HIA or the respective functional organs, like if you want to pick up, like mostly insulinoma, like 70% are insulinoma in the functional group. But one has to remember that these tumors are mostly non-functional. So if you want to remember a mnemonic, very nicely you can remember, these 70% patients are non-functional. If it is functional, then 70% are mostly insulinoma in that group. Like if you look insulinoma, then lipoma, glucagonoma, all these you can remember very easily. And all these 70% of the patients are mostly well differentiated. So they can be well treated with a different kind of therapies. Because they don't divide again and again rapidly, that's why they are very poor response to the chemotherapy. But nevertheless, they can be also in the setting of combination therapies if it is required. And most commonly, the somatostatin analog, I think is a very important component for ameliorating the functional system. But nevertheless, there are multiple trials which are emphasized regarding somatostatin analogs to have antiproliferative action. But unfortunately, they don't have cytoreductive capacity. The cytoreductive capability of peptide receptor radionuclide therapy is the key point here for a take-home message. I think you must see, but it should be really evaluated. Then subsequently, the patient should be offered this therapy. And gradually, it has taken a center stage now across the world. I think India has laid two things. You must take a pride from India that the lutetium production goes 20 years back to this country from BRC, the Baba Atomic Research Center. That's how it paved the pathway. Because the production of lutetium is a little easy because of our reactor in the Bombay. And the second part is the labeling that the chemistry people who are there in our country from BARC, I think they started labeling. And subsequently, the All India Institute started doing the basic dosimetry measurements of this. And subsequently, it has been quite popularized by Radiation Medicine Center in Mumbai. And I think gradually, it has taken up the center stage now. And this is a very important component for therapy in metastatic neuroendocrine tumors. Thank you all for patiently listening. I think now Dr. Subhash, please.
Thank you for the and it was very challenging start for both in the cases of neuroendocrine. I completed all the treatment. So, or maybe you might
Thank you. I think most of the things have been said. The message we want to give out here is that the relevance, the basis, which have been nicely brought out in the presentation, and the acceptance of this therapy internationally. And we are now fully geared to, deliver this therapy here. And so we want to spread the awareness that you can send these patients. It can be, looked in way for the surgeons that when to resect and not to. So if there is a single small lesion, the idea is to go and resect it. But when the metastases have already taken hold and there are multiple these things, these is a kind of disease which spreads silently. So by the time, as initially said, 60% of these patients come when they have already metastasized. So it's a very silent, slow-growing disease. But as the later trial has shown, we can effectively make it much more slower and show the morbidity and the quality of life is much, much improved. So there is very strong evidence there. And of course, as mentioned, lutetium, which is now produced in India, has made this treatment available at reasonable cost in India, around 45,000 each charge. So 45,000, obviously sounds like a big sum, but a lot of corporate hospitals are doing it. So there the dose is, one dose is 2.5 lakhs or 3 lakhs versus 45. So there is now, it's within the reasonable, reach from the people who can get some funds or have their own funds. So there is a huge body of data which has come out of India, which the international community has acknowledged because of this and other therapies we call the theranostic group we are doing. So I think with this, that this is available, please use it. So I hand over for the discussion.
From the surgical gastroenterology, oncology is there, or radiotherapy to make any comment? Now the comments are invited from the house. Any comments? Yeah, Dr. Sanjeev.
There is an emerging concern about development of MDS and AML with use of lutetium dotonate-based therapy. Progenitor stem cells and pluripotent stem cells who are CD117 and CD34 positive, they have receptor for somatostatin type 2. And that's why there is a more uptake of this compound by this pluripotent stem cells. That's why there is a marrow suppression, and it leads to MDS and AML. In some series like Vision 3 and French series, it is as high as 20%. But surprising in your case study, none of patients have developed grade 3-4 marrow suppression or any AML or MDS.
No, it's very nice that you demonstrated that the somatostatin receptors are expressed, but nevertheless, till today, whatever the consensus is there and the published literature is there, then these suppressions is yet to be seen of that grade of suppression. Whatever we are seeing is mostly transient, and they are just that's the major reason for which we wait for 8 weeks just to see that the counts come up, whatever the transient suppression is there. But hopefully, because this is almost back to 20 years now, because the first initial group, India also played a key role as a fourth into the country. I think the lot of literature already published regarding internal radionuclide therapy. I think this apprehension has to be really relieved. Means it is not, unless until you go beyond the critical dose of what you are delivering with the peptide receptor radionuclide therapy.
Okay. Dr. Krishna.
Out of 13 patients, how many were functional and how many were non-functional? And apart from this somatostatin analog is usually affect functionality rather than cytoreductive. Or does it affect both? That is what is not clear. Because most of the cases, what we have shown is the cytoreductive effect of the somatostatin and what we have given us to lutein. And the third point is that why don't you give octreotide or first before giving it to lutein peptide? And you also said about SSTR2 receptors are the most common. So what bottleneck does it classify that this is a SSTR2 or SSTR5 or what kind of receptor does it take? And why the one patient which was not responded, what was the receptor? So I think that before starting, we should also look for the type of receptor.
I think the comment is quite valid. The expression of 2, 3, 5 is well known, but when you want to give therapy, you have to select 2 and mostly the affinity to 2 with this peptide, whatever you are utilizing, is much more. It is almost 40 times more in comparison to the other receptors. That's why dotatate is chosen. Or the second line, if you want to address both 2 and 5, then it is dotatok. Okay. Coming to the SSA, definitely this is a standard form of therapy for amelioration of symptoms and anti-proliferative action, but nevertheless, they don't have any cytoreductive capability and they are already metastatic. If the symptoms persist, besides giving again and again SSA, which will be equally not cost effective, and that's why it is chosen following SSA only. These patients are never referred without utilizing the somatostatin analogs.
One thing, he wanted to know one patient was not responded.
Oh, it is well known now, the pancreatic tumors, because of different receptors, they are not responding. If you look to the pancreatic and bronchial entities, these are a little poor responders. That's why the combination therapy is coming into the play for the pancreatic in comparison to the small intestine. Even the trial, if you look really meticulously, I think this trial is to mid-gut NET, that is small intestine. That's why they responded extremely well. But nevertheless, this is tried now on this basis of multiple expression. I think the things will come up soon with a combination of therapy who are non-responders. Or the second line from nuclear medicine is alpha emitters, already published by All India Institute, first time in the world. And I think this is also there. But because of the production difficulties, that's why the alpha emitter is not coming to place like lutetium. But otherwise, soon it might also be placed for the non-responders.
Dr. Poddar, nice presentation. It has been shown that neuroendocrine tumors go in the metastatic disease, median survival shown to be 2.8 years, if I got it correct. So, how much gain we get after this PRRT therapy? Survival benefit, and what is the experience of this 39 patient? What is the median survival of this 39 patient who receive PRRT for metastatic neuroendocrine?
Actually, we didn't calculate about that because it is too small, and this is a series where encompasses all kinds of patients. But you saw the metastatic patients which we demonstrated in the, I think, 4th or 5th case, which has a very disseminated metastasis. I think he is living for 6th year now with that bronchial NET with multiple disseminated metastasis across the liver and as well as the bones. So obviously this is increased, but if you look to the trial very clearly, there is a 3% versus 18% response. So that is quite significant, almost 6 times than the standard SSA in comparison to PRRT. So it is expected that these patients will live longer without any symptoms. That's where the key to the peptide receptor therapy.
Okay, thank you. Dr. Preeti,
taking Dr. Krishnani's question that how many were functional and how many were non-functional, because it will tell us the response. And how many of the patients had carcinoid crisis after getting PRRT? And you said it's a day therapy. So who are the patients whom you would like to follow and because they are likely to develop carcinoid crisis after therapy. And patients who already have a bulk of disease, when do you give the dose of SSA after PRR?
I think, Dr. Preeti, I just forgot your multiple questions. Can you repeat one by one? I will be able to answer you very.
You remember Dr. Krishnani's question? That's not fair. Yeah, I said how many were functional and how many had carcinoid crisis after PRRT? Because that can be life threatening.
Can you tell? Out of 39 patients, 20 were functional at the time of presentation.
So, and how many after, if you gave 167 doses, so how many patients after the doses developed carcinoid crisis?
Ma'am, we have data of one patient only, two patients are out.
So how do you said it's a daycare therapy?
Yes.
That means you discharge the patient in the evening?
Yes, ma'am.
Who are the patients whom you would like to follow up or not let them go the same day?
Ma'am, during the first therapy, we keep patient overnight for the to look for the development of any neuroendocrine crisis or not.
You said it's a daycare therapy.
It is a daycare therapy, but for this only, for the first time, when we administered this cycle for the first time, the first cycle, we look for the early development of any carcinoid crisis. We follow patient overnight, and after that only release the patient. If there is a
But that doesn't relate to the dose of the.
No. I think,
Anytime.
I think, Dr. Preeti, your question is quite valid. Let me explain you. I think the first thing is if a patient has hormonal symptoms that we measure from 24 HIA, and that if it is there and the burden of the disease, if it is high, I think these patients should first get SSA. Okay. And subsequently, you can treat them with PRRT. Even if you are taking more than 3 times the hormone, these patients, I think you should be mentally ready when you give PRRT. Simultaneously, if there is any kind of carcinoid crisis, I think it has to be given from minimum dose of 100 microgram of octreotide infusion and short acting, and it can increase up to almost 1500. But if you given a patients, I will prefer that I give SSA, stabilize them, then treat with PRRT rather than directly treating them with PRRT. The second group is definitely a high burden of the disease, with even if they are non-functional, you have done, but still they should be cautiously treated because they will have lysis, just like a tumor lysis syndrome, these patients can develop and they can cause a difficulty. That's the major 2 points where one has to be cautious that these patients should be kept rather than daycare. You should be able to admit and keep them.
Thank you. Dr. Sinha? Yeah. In my understanding, patients with localized lesions responded partially, and those with the metastatic lesions responded very poorly. There could be 2 reasons for this. One is that we have kept the dose deliberately low so that there is no untoward radiation damage. And second is that nutrition could not be toxic enough, and as I said, alpha emitters could be more appropriate in this situation. One more thing which I wanted to know that whether any non-isotopic toxins such as ricin, etc., is being also tried for conjugation with these peptides. Probably they will be more safer compared to radioactive peptides.
I'm sorry, I couldn't follow really what you are, what computing in comparison to the radio receptor.
So what I was saying that response was either poor or partial. Is it because we have kept the radiation dose deliberately low?
No. This is the standard empirical dose which is across the world practice. So definitely it is currently with the available dosimetry data that maximum dose to the critical organ should be not be more than 23 gray. On that basis only it has decided that 150 to 200 millicurie of therapy should be given in each cycle. So it is not low.
And second thing,
And our objective is extremely clear that it delivers from the lesion dosimetry, it has been proved that mostly it delivers more than 75 gray to the individual lesion, which is a tumorous. That's where we play this role. That means quite high.
Second thing you said that maybe alpha emitters will be better option.
Oh, that is because they are quite specific and they have a high linear energy transfer. So obviously they will kill the cells much better because they cause double stranded DNA break in comparison to the single stranded DNA break with lutetium 177, which is a soft beta emitter. You know, the beta emitter is utilized for tissue destruction. Alpha emitter is also utilized for tissue destruction, but they cause, because of the high LET, they cause a double-stranded DNA break. That's why they are very specific. That's why the second line of therapy from nuclear medicine will be alpha emitter therapy, which has already been published now with the 225 actinium-based dotatate.
Okay. Dr. Moinek, you wanted to ask something?
Extremely well. It was, I think, probably Kanish could have added many things. These patients have received almost more than 6 times the somatostatin analogs prior to coming to us. And he had a multiple dyspepsia, low back pain, and subsequently operated at King George Medical College and came to medical oncology at RML, then subsequently came to us after almost 6 years. And definitely he has incapacitating symptoms, which was not controlled with the standard analgesic and octreotide. That's why he landed up with us with PRRT. And following the Dotanov imaging scan, we realized, nobody realized by that time that this has so much of disseminated disease. That's how we basically started with the PRRT. And we are extremely happy with this patient. Now you see that after 6 years also, he is doing pretty well. He has built up 2 homes in his state and he requests me that you please build up a home in Lucknow.
So, any comments from the resident doctor? Any comments? Okay,
Yes, Doctor, I think that.
very brief lab.
What you were asking? Albumin.
Amino acid is usually of written for the
Oh, amino acids are actually positively charged amino acids, lysine and arginine. They basically, these isotopes go and bind to the proximal convoluted cells and they through the megalincubulin system. That's why they basically protect these with these positively charged amino acids. So that's why it doesn't go and bind there so that the chronic toxicity in the long term doesn't occur.
amino. Amino.
It is amino acid.
I again thank the department.
Thank you.